Hello, welcome to First Friday Fertility. I'm Dr. Preston Parry, and today we've got a little bit of a different setup and layout because what I'm doing with this is something that normally is reserved for med students and even for residents. So if you are wanting a deep dive to understand a lot of the core principles of fertility, this is what the doctors are taught. But as always with anything, again, coordinate with a specialist, see if this does apply to you or there's new discoveries that might change what we know. But these are general medical principles that for a lot of times help shed light on where people stand. How do you test the uterus? Well, here's what it looks like a little bit on saline infusion sonogram. That's an ultrasound with some saline. And you just see that smooth cavity. That black has just this nice sort of elliptical quality to it. It's very normal there. This is a 3D ultrasound, looking very normal for that. And then this is a hysteroscopy. You look inside and you see a smooth cavity, and the two dots, those are where the fallopian tubes connect. Again, all fairly normal. Now, these are women where she was told she was normal on ultrasound. Now, again, some people might say, hey, there's some irregularity on the left. It's heterogeneous, cystic, and asymmetric. If you look on this person on the right, though, where we did the hysteroscopy, you're finding all these polyps and all kinds of vascular things in there. So I would say, if you don't look, you can miss something. So I tend to trust the hysteroscopy for things a bit more. This was a person who was also told she was normal, failed IVF 3 times, 2 docs, one in Mississippi, one in California, multiple embryos transferred. Well, this is her uterus, and you see all those bands in there. The uterus is fused together. That may have been why things were detaching. Again, was told she was normal. This was a person who, again, failed IVF, had been told that she was normal. And you see all these little finger-like projections. That's endometritis, these micropolyps. You see the blood vessels in there. And you can see that dropped fertility by 3/4, and they're all throughout. By the way, as you get more into this bottom left corner of the screen, you see that sort of floating around. It looks like a sperm. That's not a sperm. That's a polyp. It's a tubular polyp, and you can see those vessels. Again, she was told she was normal, wasn't. And this person, by the way, was told she was normal after extensive treatment for it. It was either hyperplasia or cancer, and I'm having trouble remembering. But she had multiple biopsies, went on medications that caused her to gain weight. It took about 3 years before she was cleared. Well, you look inside and you find these areas of abnormality, these little polyps and all these vessels. And so a lot was cleaned away, but a lot was left behind. This is something that hysteroscopy could have picked up instantly instead of years of biopsies and pain and delay. So I'm a big believer in hysteroscopy for understanding the uterus. Now, for the tubes, I think all current methods for the evaluation of tubal patency have technical limitations. That's National Guidelines from 2012. I think HSG, you look at these, they can hurt. And you can get some spasm, and people debate what the accuracy is, but it's often lower than people think, especially because high pressure patency doesn't always reflect physiology. The sperm don't swim at the jaws of life. You can't blow open a closed tube. And even if a tube is strictured and you can force the dye through, there's been research showing that if you have high pressure patency, you can have 1/4 of the fertility as if it's spontaneously open. So sometimes when an HSG hurts a lot, it may mean there's some damage. You think of a corroded pipe. It may not be capped, it may not be buried, but it can be closed off. Sonosalpingography is where you have the air-infused saline and you're trying to send the bubbles through. And sometimes you can find that, and that's reassuring for things. Chlamydia antibody testing, that also can be useful because a lot of people, 85% of women in theory who have had chlamydia don't know they've had it. So that's a very common reason for tubal damage. And then laparoscopy with chromoperturbation. My picture is a little bit blocking off where the tube is, but the narrow part in the sort of the top right, that's the isthmic where the sperm travel along. To me, in this broader middle section, that's the ampulla where the the sperm and egg meet and fertilization occurs. And then this 9 o'clock portion where you see the blue dye spilling out, that's the fimbriae, and that's what picks up the eggs from the ovary. And you see this person was having laparoscopy and dye was injected into the uterus, showing that the tubes are open. And so that's the gold standard. But that's a $10,000 surgery with incisions, anesthesia, and a week recovery, for many people. That's not usually a starting point anymore. A lot of us are moving away from that for things. So the classic thing with sonosalpingography, you use the air-infused saline to see if the tubes are open. And right in here, you can see these little running white bubbles going through. It's really hard to get it to look this good, but it does show that the tube was open on that side. Sonosalpingography was supposed to replace HSG, but I find that it's hard. There's a learning curve. I mean, I did hundreds of these, and I never was fully happy with what I saw. I think sometimes it's easy to do one side, but sometimes you can't get the other, and you're not sure if it's spasm or you aren't rotated enough. And then for many people, this can hurt just as much as HSG. It's kind of interesting. If you use a balloon catheter, it's pretty accurate, but it can also hurt more. And if you don't use a balloon catheter, it doesn't hurt as much, but then it may be less accurate for things. So I think that matters for things. But this was supposed to be what replaced HSG and brought everything back in the office. But we said, look, I wasn't really happy with this approach, but I knew, hey, if I could do hysteroscopy gently with a really small catheter, and then I could add some air bubbles, maybe it's really looking at doing this technique called sonosalpingography from the point of view of the hysteroscope. So what would that look like? So this is what I see. So I've got this fiber optic camera, again, dimension of a coffee straw. Well, the coffee straw is really small, advancing along the cervix, coming into the uterine cavity where pregnancy develops, a few micropolyps at the top right. So that's the endometritis I alluded to before, chronic infection, added air bubbles. On the left of the screen, that's where the right tube is. This is my left hand. Wait, it's reversed on your screen. But again, normally if a person points their left hand to you, that's your right side. Those bubbles are going through, that tube's open. I'm going to check her left tube on the right of the screen, but she doesn't roll her hips fast enough, prove that tube open twice. But again, this was about 30 seconds of time. In that time, you find a few micropolyps. So infection, $30 worth of antibiotics, many people say that's a quadrupling of pregnancy rates. So it makes a difference. There's some horizontal red lines that can overlap with adenomyosis as well as damage to the tubes called tubal osteal sunshine. And then you prove the right tube open twice and check the left in a second. Open as well. Again, under a minute, gentle, accurate, fast, safe, able to treat her, get her pregnant. And again, if you're saying ultrasound gold standard for the ovaries, ultrasound and hysteroscopy gold standard for the uterus, I still think the gold standard for the tubes is laparoscopy. But if you can add a few air bubbles for free while you're already doing the hysteroscopy, and the tubes are acting open, that's a good starting point for things. So we studied this for a bit, and we were thinking of hysteroscopy for a hysteroscopic approach for sonosalpingography. And we showed that in our publication, we got about 98 to 100% sensitivity. That's a whole story, but it was pretty good at picking up blockage, and 84% specific. So we were pretty sure that, when we saw the tubes acting open, that they were open. It was much gentler than HSG. Hysterosalpingograms just often hurt for people. For things. In fact, we had one presentation at ASRM where we showed people who had an HSG. Most of the people who had an HSG, that was a reference point for life, and they actually had less pain with the test than people who'd never had an HSG, which ended because they just said they were prepared for so much worse, and it ended up being pretty good. In fact, I think it was about 85% roughly. This was another study. 85% of those who had max pain on HSG had mild to no discomfort when we did things. So it wasn't that people were being wimpy when they had a painful HSG. It's just that HSGs can often hurt. It's easy to learn, fast, often under 5 minutes for us, and the low disposable costs, where again, we're just using a hysteroscope, a bag of saline, some IV tubing. We don't even use a speculum or swabs all that often anymore. So that makes it more accessible and affordable for people, as well as, again, often hurting less. So I think emerging concepts for rethinking uterine factors, you can't fix what you don't see. I think we're moving a lot more towards 3D ultrasound and hysteroscopy. I don't think both have their strengths, but I think that you've got to look closely at the uterus. I think we have to watch for inflammation, and endometritis and adenomyosis are going to be more relevant, and how the uterus contracts, not to treat it as this passive vessel. I would say it's like the heart contracting, and so we have to look at how it contracts. Again, I think what we know about endometriosis in the 70s is where we are right now for adenomyosis. I think Keith Isaacson has said that incredibly well. And junctional zone adenomyosis may be particularly relevant. So it's not just that you have adenomyosis, but where it's located may be important. And again, endometritis is increasingly relevant. But again, you're seeing it more with recurrent implantation failure and recurrent loss. And if you are treating it, those who successfully get it treated have double the implantation rate, double the clinical pregnancy rate, and quadruple to 5 times the live birth rate. How do you treat? And, you don't want to use a porcupine for all natural acupuncture for things. So to improve the sperm, male prenatal vitamins, honestly, I'm underwhelmed with the value. I think from what I've seen, and again, someone may say theirs are different, it's often a multivitamin with a little vitamin E and zinc. I wouldn't spend $100, $150 a month for just what you can make at GNC for a fraction of the cost. Stop smoking, reduce alcohol, absolutely. Again, even though alcohol is how a lot of people get pregnant, beyond creating opportunity, it doesn't help. And a lot of times when I see people who don't get pregnant and they should, they really had this lifestyle where it was just harder on the DNA, and they were smokers or drinkers. And that's a top thing where I think eliminate all smoking, 1 drink a day, probably fine. That doesn't mean 7 on Saturday, you averaged over the week, but I would want to improve that. Decrease obesity. We do see lower pregnancy rates when the BMI is over 30, and especially above 40 and even above 50. Losing weight can help. And avoid most lubricants. A lot of lubricants just tank the function of sperm. And, what's interesting is KY jelly, can actually kill sperm. There's a myth on the internet that say, it makes the sperm more slippery and they get where they need to be. Nope, doesn't. And interestingly, canola oil and olive oil work pretty well for keeping sperm alive, but I don't want anyone to get vaginal infections from, having food products in the vagina. But anyway, that most lubricants are not sperm friendly. So you have to be very mindful when doing that. For timing of the sperm, this was a great study by Wilcox in New England Journal of Medicine. And what he showed was, everyone treats fertility as this fire drill. They do the LH predictor kit. It's positive. Everyone says, go, go, go. Wilcox showed if instead of just trying to rush when the LH predictor kit is positive, if you had sex on the day of ovulation, 1 day prior or 2 days prior, pretty much no difference in the pregnancy rate. So I say there's a 72-hour window. If you have sex 11th, 14th, 17th, even 20th days of your cycle, with day 1 being the first full day of heavy flow, that's covering your bases for when most people ovulate. And you don't have to do the LH predictor kits or basal body temperature charting. Basal body temperature charting just tells you whether you're regular or not. Well, if you have a regular cycle, most likely you are. So I just say, have sex every 3rd day in the window that matters, and some people just say, hey, let's do this Wednesday and Saturday. And that's good enough. And if that's not covering things, most likely there may be another source. Now, by the way, some people can have really bad sperm counts where there's a shorter window. They can have damage to the cervix from previous cryotherapy or chlamydia cervicitis, where the half-life for sperm may be less because they lose the crypts. But most people, they should be fine with the every 3rd day. How many times do you have to have sex on the day of ovulation to maximize chances? I've had couples come in, both of them sore, barely able to walk because they're trying to put as much sperm in the reproductive tract. Well, 0 acts of sex, kind of hard to get pregnant. But this showed 1, 2, 3, 4, or 5 times. in the days leading up to it, really almost no difference in pregnancy rates. So you don't have to force things. You don't have to try 4 times on the day of ovulation to get pregnant. That really doesn't change things. To really improve sperm, you do insemination. If you take the sperm, wash it, and purify it, and put it directly in the uterus, so the sperm doesn't get lost in the vagina, you have about a 20-50-fold increase in the number of sperm that find an egg. And by itself, 2 to 4-fold increase in pregnancy rates. You get a little bit lower returns at 2 to 10 million total motile sperm, but let's say it's a 50-fold boost. I've had people with 200,000 total motile sperm get pregnant from insemination. 200,000 times 50, that's 10 million. That's the one sperm finding the egg. That can do things. To really improve the eggs, obviously starting younger, you're 45. Most of the eggs are chromosomally abnormal. Also, don't smoke and drink. And then you recruit more. Their medications, Clomid and letrozole praise, standard. I personally find that clomiphene turns everyone into the devil from the hot flashes. Letrozole, that while that's off-label, many people do use it. My understanding is it's the majority of fertility specialists. Injectable gonadotropins, that should be very rare for when you would do that. Usually that costs too much per pregnancy achieved with a lot more risk for multiples. Metformin, a lot of people talk about metformin for improving the eggs. I'm not a huge fan. I think most of metformin's benefit ends up being from intestinal upset. So your intestines are upset. You don't want to eat. Don't want to eat. You lose weight. You ovulate. You get pregnant. I can give people paprika with about as much efficacy. I'm joking, of course, but as metformin, I wouldn't lean there for fertility therapy. And there was a New England Journal of Medicine by Rick LaGrow from about 15, 20 years ago, and it showed that really there was almost no difference between clomiphene and clomiphene plus metformin. But it was both of those options clearly did much better than metformin by itself for PCOS patients. For recruiting eggs, again, there have been some other studies. This one, I think, just captured a little more of what I see personally. If you go from 1 to 2 eggs, you get about a 60% boost in your fertility. If you go from 1 to 3, you about double the eggs. But going from 1 to 2, it's a 5-fold increase in fraternal twins. And if you do go to 1 to 3, it's about a 10-fold increase in fraternal twins. So you can overdo things when you are getting extra eggs. But this is why I tend to prefer this insemination for things, for amplifying fertility, because it doesn't matter whether it's 5 sperm or 10 sperm find an egg. The risk for multiples is pretty much the same. It's whether you have extra eggs. And that's why twins are usually carried down through the wife's side far more than the men for things, because it's on how many eggs were recruited. So here's the thing. Back to what I originally asked. year and a half of infertility or subfertility, 60% boost from oral medication. What is the change in fertility? You went from 2% times 1.6 to 3.2. Minimal boost from oral medication. So I think, if you say eliminating tobacco, alcohol, and caffeine, under 200 milligrams for caffeine, that's usually about a 40% boost for things. So I would say that Clomid by itself is about as effective as that bit of lifestyle modification. Now, for people where it really matters, Gosling's didn't have IVF. John and Kate +8. This was from the picture of their book to give the credit to the source. My understanding of the story, and it may be wrong, I apologize if it is, and please someone correct on the post if they know anything differently. But my understanding is she, about 26, went to a fertility specialist, ended up with twins. She then went to her local doc, thought the commute was too far. The local doc thought he saw 3, maybe 4 eggs. I believe she actually had 5. She had septuplets initially, where 1 spontaneously reduced, giving her sextuplets. But she was anovulatory. She didn't need 5 eggs or 7 eggs, or even 3 eggs. She needed 1, probably 2 tops. The point is, this was someone who's really high risk for multiples because she was going from 0 eggs to 1, 2 plus. Those are people who have high risk for multiples. I would say you want to look at where people are. In ballpark, this is where I am. And you have to individualize. But if you have never released eggs, you're young, and you're trying less than a year, you may want to be on the one egg side. Conversely, if you've been going 8 years, where sperm and egg have been finding each other for years, you're ovulatory, and you are over 40, where a lot of the eggs are chromosomally abnormal, you can probably get more than 3 eggs and have a reasonable degree of safety in that place, where you would never do that with someone, say, at the top of this figure. So you want to see where people are for tailoring yield. But again, I think this is something to really emphasize. It's not just, hey, here's a pill, let's see what happens. You want to really understand where their risks are for things. And so I would say, ballpark, this is where things are. For spontaneous oral medications, what we often see with our IUIs, if they have tubal patency, if they're, and this is, again, there are exceptions. If you find that they have ovarian failure or other things like that, you're not going to give them 15, 20%, but we overall see about 12%, 11% with our inseminations, but that's including a lot of people where they're much lower chances. IVF nationally, actually, some of the newer numbers are pointing to 42%. For us, the cumulative take-home baby rate under 35, I think we're closer to 62, but a lot of it's not everyone is 62. There are a lot of people who are closer to 82. You will just have these people where they're ovarian failure or stage 3 to 4 endometriosis or some other factors, which you've got 4 people who are 82 and 1 person who's 10, throwing off your overall odds. So that you want to tailor the individual odds for things. But again, this is ballpark where I see a lot of things. You have to tweak these numbers and individualize them for things. And by the way, this is Louise Brown, world's first IVF baby. She is exceptionally gracious and personable, and tells her story for so many women, and is a champion. Just a lot of love and respect for her for things. And Elizabeth Carr is the U.S.'s first IVF baby. Again, she's also done great things. I appreciate those who share their journey and help others on the path. So for how you do IVF, you get the eggs lined up, you get the eggs to grow, you take the eggs out, you fertilize them, plus or minus ICSI, which is putting the sperm directly in the egg, and then you freeze the embryos for whatever you are not putting back. There's some data that actually show you can have a higher pregnancy rate even with freezing embryos than with doing fresh. And there are circumstances around that, so that's individualized. You talk about whether you do PGT, to understand whether the DNAs are normal or abnormal, and then you transfer an embryo. So ICSI, this is how ICSI looks. You can see right there's a little sperm in the tail or the tip of the embryo. You're introducing the needle into it. And by the way, you can see up top, there's this little sort of circle or semicircle on the top of the egg. That's the first polar body. You sort of are taking a little bit of the cellular machinery out, or the cellular cytoplasm out, and then you're reintroducing the sperm. By the way, you'll see that the sperm had its tail broken so it doesn't thrash around inside the egg and break it. And that can help a lot of male factor for things. So that's putting a sperm in the egg. The biopsying the embryo, before we even get to that, if you look at the egg that's being surrounded, and by the way, I'm not sure of the source for where this is from for this particular video, but credit to whoever it was for sharing it. If you look at this, you see this little gray, and that's the zona pellucida. And so as the embryo grows, you will see this ball of cells. You want to harvest from somewhere away from where the embryo is and more from where the cells are within that shell. You use a laser to drill through, and then you take 6 to 10 cells from the future placenta. And if you're doing that helps keep you away from the embryo or the future pregnancy that is, again, non-placenta for things. People refer to the fetus or the embryo in that context. One thing, you can have people and by the way, this is much more embryos than normally get, but you can see that a lot of people can have embryos that are chromosomally abnormal for things. And so that's why even not all of these would take. By the way, this is a transfer. You can see a little white catheter, and there's that flash of white. That was the embryo going back there. That's the moment of conception where the embryo got into the uterus for things. So that's a lot about how you look at IVF. Can you improve the tubes? I say not all tubal damage is the same. So you can have a buried pipe. That's one of the things to think about. You can have a capped pipe. And so the buried pipe is where you have scarring around the tubes. The capped pipe, the tubes, the tip of the tubes, the fimbriae are fused together. And you can have a clogged pipe. I worry most about the clogged pipe, the internal damage. All these people are talking about, can you flush the tubes? Look, I'm not worried about a little debris. What I'm worried about is inflammation. If you have pelvic inflammatory disease or something else that scarred the inside of the tube isn't a pipe, it's a conveyor belt. They're little hairs that push the sperm and egg together. And when they meet and form an embryo, the hairs reverse direction and push the embryo back to the uterus. Sperm have a tail and can swim, but the egg doesn't have a tail, it can't swim. The embryo doesn't have a tail, it can't swim. And so if those hairs are damaged, the sperm and egg can't meet. And then if they do meet, the embryo is likely to get stuck. And then you have an ectopic or tubal pregnancy. This is one of those things that people don't get. They just say, well, can you open up my tubes to a roto-rooter? If there's a lot of fibrosis or damage, you could take a power drill, make a hole in the uterus. But if you've killed those hairs, it doesn't matter. Sperm and egg are just unlikely to meet. And again, the pregnancy rates are really low, even if you were able to open it up. So a lot of the times where people say tubal surgery fixed things, it's really because there was spasm and there wasn't tubal damage, or the tubal damage on the inside wasn't bad, but the outside was, or people just got lucky. But, you can't repair the hairs. The cilia that push sperm and egg together, there's no magic way of causing them to regrow. And so you really have to understand how badly the tubes are damaged. And for the uterus, there's a lot to do. You want to restore normal anatomy. You want to get rid of polyps or get rid of fibroids or get rid of scarring or adhesions or septae when the uterus was born with fusion in the center. But that's a whole talk in and of itself. So in summary, the most important things to think about, how long fertility has gone, it matters just as much as age. You want to think of where the chances are for a 30-year-old trying for 18 months, running roughly 2% a month. You work up the sperm, eggs, tubes, and uterus for your most efficient path. And if you're ovulatory and needing therapy, try to go to oral medication combined with insemination, not just pills, which might just put you from 2% to 3%. And I think that's much of what's on my mind. Questions, post them below. But that is a long-winded version of the essentials most doctors should know to understand fertility. Many of you are now knowing as much as many doctors do. And I think there's a lot to be hopeful for. There's a lot to do. If you like this video, share it, subscribe, follow us, and let me know questions, and we'll try to cover them either directly or in future posts. And again, this is always general medical information. Find out if things are specific to you or whether the state of knowledge has evolved. But this is much of how I see the world. Thank you.